Welcome to the Global Health Forum. I'm going to just allow myself to just indulge my personal curiosity. Your involvement with World Government Summit and the UAE, bring us up to speed. First time, long-term friends of both the summit and the UAE. Dr. Sangeeta, to start with you.
So truly the first time for me. I'm not in the government. I work at Apollo Hospitals. We're a large private sector organization. We do work in what we call the PPP, or public-private partnership, with the Indian government. And we've treated patients from over 140 countries. So I'm very excited to be here.
Fantastic, and welcome. Thank you very much for that insight, Dr. Sangeeta. Luba, yourself.
Yeah, so thank you so much for having me. It is my first time here at this conference, but certainly similar to Dr. Sangeeta, have done work really globally with a global reach. So thank you for having me.
And an insight in terms of the work that you do.
I'm sorry?
An insight in terms of...
Oh, into the work. So I'm working in the biotech and the healthcare space. I'm running investments and also building companies around healthcare, both delivery and bringing artificial intelligence and technologies to improve outcomes in the therapeutic space, but also healthcare delivery space.
Fantastic. It's really good to hear that from you yourself, and you'll be key to the conversation. Emil, yourself, new to World Government Summit and the UAE.
Sure. Thanks a lot. I'm honored to be here. It's the first time for World Government Summit, but not the first time in the UAE. So I come from a very Nordics of Europe, from Latvia. As a digital health startup 6 years ago, we embarked on a journey to support the flagship program of Emirati Genome here with our digital solutions. So, and we'll be talking about this scalability and cross-border collaboration I will be addressing through my comments later on. But this is first time during the summit.
Fantastic. Again, welcome.
Thank you.
So to my panelists, we've been tasked with this very intriguing title for our session, which I think really is very thought-provoking. From bits to bedside, real-world applications of emerging health technologies. Dr. Sangeeta, what are your thoughts on that? What should we be having at the forefront of our mind when we speak about this?
So I think the potential for what we have in front of us is incredible. The stages that countries and institutions are in are vastly varying. And the infrastructure required to do this is also very varying. This is a World Government Summit. But I think if you look at it very simplistically, it's the beginning of first digitalize so that you have the data, create seamless environments, study the analytics around it, streamline the regulation, and then accelerate adoption into high-impact areas. And there are many. So I won't go into this. We can talk about it during the application, but that's really what we've been trying to do. So within our healthcare ecosystem, we've digitalized, we see a patient, or we created the personal health record. So a patient, about 18 million health records throughout their journey. We also look after a population of about 70,000 people from birth through life. So we're looking at population health, we're identifying early incidence of disease. We're focusing on lifestyle-related disorders or non-communicable disease, which are really the biggest thing, and focusing on health span using a multitude of things. So I think the ability to set the foundations, pick high-impact areas, accelerate towards democratizing, and focus on proactive, preventive healthcare first, while you continue to enhance your infrastructure for high-end care, train your workforce for the new world that's coming or has already come, and ultimately accelerate and use this data in the most global democratic way towards new cures. So, long answer, but it's a complex environment.
And it's a very interesting answer because, again, you echo what we've been speaking about so far today,
Absolutely.
Those workforce challenges, and also where we can, the key words there, I really want to bring Luba in here on, high impact areas.
Yep. Yeah, absolutely. And if I may also just to add to Dr. Sangeeta, you're absolutely correct. And what is BITS? And how can you make impact? So about 10 years ago, I was the head of mergers and acquisitions at a global pharma company called Roche in Switzerland. And we're the first to acquire a company called Flatiron. And Flatiron Health was the company that said, right now we have electronic medical records, and that's great. And to Dr. Sangeeta's point, just because you have electronic medical records doesn't mean that you can draw insights or have impact. or have the training, the workforce that can even work with this data and information. So the idea behind the company was, let's take everything from the electronic medical records and magically you will draw insights. The problem was it's really hard. Number one, you don't have information on electronic medical records that is actually helpful to you. You don't have things like lab data, imaging data, and getting information and merging imaging data, lab data, family history, wireless data that we're continuously monitoring, such as now you have continuous glucose monitors, which we didn't, by the way, have 10 years ago. We're only starting to have that. It was very hard to, people talked about it, digital health, personalized healthcare, genomics, but it was not realistic. And then you had, all of a sudden, you had large language models. So we talked about AI, but even before LLMs, before the large language models, we were unable to truly realistically, if we were honest with ourselves, we could structure the data, but we are unable to really draw any insights from that data, or on a continuous basis, being able to establish what's called a baseline for an individual. And really treat that individual. So the world has changed now. Because you have large language models, you have access to also global data that has been stratified, especially in places like Latvia, Estonia, that have done such a fantastic job on collecting banks of genomics data, other omics data like proteomics. So we are really in a wonderful, lucky position. But to Dr. Sangeeta's point, the only way to make impact is actually knowing how to use that data. How do you deploy those insights? And how do you prioritize? Because people talk about all sorts of different things, and it's really exciting, and you have a lot of meetings. But then, okay, what do you actually focus on? So a lot of the things that I'm working on, and one of the reasons I was brought into Dana-Farber Cancer Institute, is to actually figure out what technologies you will actually make that impact. And I can go into depth later on about what those technologies are.
I want to hear about that, and in depth as well, because I'm sure my esteemed audience are here taking notes as I am. Now, you mentioned there the idea of it's not necessarily only a case of collecting the data, it's analyzing the data and then extrapolating from that. What are the key points? You seamlessly allow me to bring in Emil. You provided a good promo for Latvia, Estonia, the region, in terms of how we can look at what you're doing as a blueprint. Please share with us, Emil.
Sure. So thanks a lot for addressing both Baltic states as well.
My mother is from Latvia, so I.
Oh, Little speaks. Very nice. So yeah, first and foremost, we talk about data and bits. And for me, as a computer scientist, it's all about telling stories from data or collecting these bits and pieces all together. So when we talk about collecting the data, and exactly the same challenge that we encounter, we introduced the patient-reported outcome measurement system in oncology, multiple sclerosis in Europe as a startup. And then what we encountered is that okay, we collect the data. But then we just saw a study published on Lancet that only a third of HCPs, the healthcare providers, can actually extrapolate and utilize this data for actual clinical outcomes. And this is exactly the point that you're addressing, that it's not only about the collecting, but actually switching it back. And second of all, when we talk about the technology per se coming to the healthcare industry, it should be as robust as possible. So my colleague here has O-ring, am I right?
Yes, of course.
Yeah, so this is the good example of the unobtrusive and robust monitoring technology, because we're sitting here in the panel discussion, meanwhile, the ring analyzes the data and drives insights for well-being or longevity and other perspectives. And if we talk about technology, we should talk from both perspectives, both institutional, local-wise, and then cross-border-wise. And there are some certain, not challenges, but points to address in order to introduce such. First and foremost, we should not be only tech-driven, but rather perceive technology as an instrument. I like to call it a 21st century screwdriver. You can use IKEA furniture to build a nice living room, and you use the screwdriver in the same technology. But we should somehow build this dialogue between the cross competences. So myself coming from computer science, I should have a dialogue with HCP. I cannot imagine and lean in the head of a professional and then put the solution in front of him, rather than I need to feel the challenge or the pain and address it with the help of the solution. And second of all, for sure, it's all about building local and going global, and not only government-wise, but also pharma-wise. What I've seen working with global pharma is that per market, they have very similar solution being developed or validated, but in the end of the day, it's all about sharing this experience and how can we build solution in the UAE as an example and bring it and erase these geographical borders and bring it to the Nordics of Europe, to the US or other regions. And this is something that we should address both on policy making as well as validation-wise, have it very transparent in terms of scalability.
Emil, so many interesting threads. I can pull on many of them, but to focus on one of them in particular and bring in Dr. Sangeeta, you said the words there, building local and going global. Dr. Sangeeta, from your experience, what are some of the things that we could learn of? What are some of the examples that you can share about the work that you're doing?
So I think that across a range of areas, there's the easier ones, the lower risk ones, which are really related to productivity and operations, faster discharge summaries, ambient listening, and we've been working on these to improve productivity. Next, you move into the clinical areas, which are very vast. But in clinical, I'll start with screening environments. So we did about 7 years ago a cardiovascular risk screening along with, a large tech company. So we cannot screen in India 1.5 billion people, but we can definitely begin to look at high-risk populations based on a simple lifestyle assessment score. Then you know where you need to focus. So that's what we did with our AICVD. Then you use the risk score and you educate the person that this is your risk score. If you do A, B, C, D, let's bring your risk from high to moderate or moderate to low. And this, when done at a population or a large cohort level, means a healthier population, health span that they were talking about. So this is one of the big things we've done. We do about 2 million health checkups per year. And in those health checkups, we're counseling these people. We're using AI. We're using the nudge theory. We're using the mobile phone to stay engaged with the individual to reduce risk. But if you say, okay, your cholesterol and this, but it's not just the 5 known articulated factors which create the risk profile. It's a multitude. So we have 27 factors that we've now put in an upgraded equivalent of the Framingham Heart Study and use that framework towards risk reduction and educate the individual that this is what you're doing, step by step. Diabetes under control, blood pressure under control, weight under control, better sleep, healthier food, the whole gamut. But it's in a simple, understandable score, so the doctor or the clinician or the health worker is able to have a meaningful discussion. So like this, we do pre-diabetic risk. We've embedded tuberculosis risk into routine X-rays. So across, we've offered this free to the government. We're using it in our environments. So there's a range. We have about 29 major algorithms, 17 of which are MDSAP approved. So these are in the clinical area. Then I'll go to the next one, which I think is another very important, which is embedded AI. So when you look at the skill gap in technicians, the best way is to make the machine smarter by embedded AI. So we're working with a large manufacturer to put AI into the ultrasound Doppler. So for example, non-alcoholic fatty liver diagnosis, most often missed because they forgot to click at the right time or they didn't know. So if the AI can do that, that would be transformational. So like this, we have, a multitude of things going on. The last category, which I think is, the one with the biggest promise and the biggest hope, is really the pharmacogenetics. So when we look at, you said bits, the framework that I would apply actually is the 3 Bs, which is biology first, because the genetic makeup is what dictates the presentation of disease. So it's biology, it's bits or bytes and computational power, and it's bandwidth for global access. And if you combine these 3 in a framework of analytics, in a structure of AI, in an aspect of continuous clinical outcomes, with this virtuous circle back into action. You may have the clinical insights, but you have to do the action to get the outcomes. So this is really the framework which we're following at Apollo Hospitals. We have 73 hospitals, high-end cancer. We get patients from all over the world. But we're also focusing on primary care, rural care, mobile vans, population health screening, and a lot of AI. So I think frameworks like these are what can make groups of population healthier, like one community at a time. It is not a sweep. Every community has different problems. Every community has different disease presentation. But a universal framework, a proactive preventive care, is really where the future is. And then at a global level, if we could collaborate on the breakthroughs in science, we should not do silos of knowledge. If we bring these together, like during COVID, how did the globe, decipher, create a vaccine, everything in 9 months? Because all scientists work together. The health crisis or the health emergency is so large that it demands that we work together.
And I think that's such a comprehensive, holistic, but also inclusive approach that you've outlined for us there. So thank you so much for sharing that. And it gives us so much fertile ground. Luba, you mentioned about technologies, but building on what Dr. Sangeeta spoke about there, the advanced technologies, but empowering people, teaching them about risk reduction, giving them the information to act as well. So what's that balancing act? And you teased us with some technologies you're going to give us an insight in terms of, so I want you to share them with us now.
No, sure. And actually, there was a recent paper about, for example, agentic AI, so using agents, and it had showed that the outcomes have improved when you have an agent and a healthcare provider. And that's something that Dr. Sangeeta was talking about, the importance of basically complementing, augmenting your healthcare provider, be it a physician or a nurse or tech, with really exciting new technologies, but also an ability to do that. And we'll talk a little bit also bias, because bias is important when you're trying to implement technology, especially globally. So you want to make sure you have cultural sensitivity and take out bias or not understanding of what a healthcare professional understands. If I may, can I give you an anecdote?
Yes.
Which will give you an example of this. So when I was at Google, we're building out life science tools. Actually, one of the things, earlier panel was talking about detecting diabetic retinopathy was something that came out of the technology that we're working on, which is wonderful to see it being implemented globally. But actually, it was the same team came up, the head of product, and was so excited and said, we collected all the data, all the bits out there, and we learned very important insight. I said, what is this insight? He said, if a elderly male comes in has a high elevated white count cell at 3 a.m., he's 10 times more likely to die than if the same male has elevated white blood cell at 3 p.m. And I said, well, have you talked to a doctor about it? They said, no. Remember, a lot of people are very young. They're 20, 21, 22 that are working on gathering the insights from this data. I said, well, isn't it because maybe the person is in the hospital at 3 a.m. and is likely to die, but not because of the white cell count, but because of some other issues, a comorbidity, than if a person is coming for routine 3 p.m. blood draw. So it's these kinds of things that it's quick to basically grasp and say, oh, we learned an insight. We can detect who's better to triage. We can detect who's more likely to go into the ICU, who's more likely to have sepsis, which is another thing that's very important to understand and triage properly. But you always need a healthcare professional, an actual human being that is an expert next to them to make sure that, number one, you're making the right product, and you're making the right product also with not bias and sensitivity and approach and how it's going to be deployed as well. So it's some of the things that we think about beyond just the technology when we're putting it together. And what Dr. Sangeeta also said, the insights that we draw to actually make better drugs. So genomics is important. Another thing is epigenetics. Just because we have a genetic predisposition to something, let's say a heart disease or a particular cancer, doesn't mean that it will get expressed and we will actually get that disease. So isn't it fabulous that you can now actually monitor and you can see whether or not, and collect all that data and see whether or not you can do something preventative or you can diagnose this earlier. And that is some of the products that right now people are working. But again, you want to work globally. At the end of the day, we have cultural differences, but we're all the same humans. And we have different patient journeys. So one of the things that is, if you do want to have more global reach, is have a patient journey for a certain disease, certain comorbidity, certain individual, because a heart disease presented in one country is quite similar how you treat and how you approach it as a patient journey as another part of the world.
And I think
May I make 2 points on this,
yes,
please? So one is, I think, on the point that you said that the The treatment cycles are same in different parts of the world. I think we now have the knowledge to say that we need to differentiate.
Yep.
For example, in a large-scale study that we did, the PSA norm globally is actually underexpressed in India, and therefore we were missing prostate cancers because the value is wrong. So this normalization for populations and using a diverse heterogeneous data is very, very critical so that we don't have these queues. The other very quick point is that we must look at technology to augment the doctors, to assist the doctors and not replace them. Because unless we have the doctor, to that beautiful point you made, unless they are the center of this care, we will be missing a lot. And if we communicate this wrong at this point, we will create barriers.
And I think you're absolutely right, because we're at a defining point where there is some reticence,
Right.
and that's, to put it mildly, across the industry, as many industries, as well as acknowledging the advancements. Emil, I know that you've been patiently waiting. You, of course, teased us earlier there with a very exciting word which resonates very strongly here, genomics. The UAE is at the forefront of genomics research and collection and data analysis. Give us an insight in terms of what's happening in Latvia, and more broadly speaking, because you're working on some really exciting projects.
Sure, and exactly what the previous speakers told about, that we can differentiate both the patient journey, and this is where technology can help us, through the personalization and driving both the patient as well as the HCP throughout the patient journey, starting from pre-screening, even ending up, with the good outcomes in terms of rehabilitation treatment. And this is where UAE is in the forefront. We're very happy to collaborate, because in the Nordics with Tartu Biobank and in Latvia, we were also one of the first to digitize the process in terms of collecting the genomics and trying to interpret this in terms of building this map, in terms of understanding the prevention, how can we tackle certain related things like hereditary mutations in breast or ovarian cancer. The BRCA mutation is an example. And the UAE is now built the world's largest genome bank, and this is all about now personalizing the pathway afterwards, because when you engage the broader population, you inform them about the benefits and the value scientifically and also clinically, then it's all about how you can put it in the front of the eyes, in the right place, in the right time, and then navigate them. And this is what we built actually, and bringing also to the UAE now in terms of breast and ovarian cancer through digital tool. We 5 years ago, we started digitizing the screening process, because we started off with, my mom received a letter from the Minister of Health and the CDC in the Baltics stating that you should be at screen for cancer. So she was totally afraid. What to do, how to dress up, where to go, how to, what to tell there, etc., etc. So we built a digital tool there where we navigate individuals through dynamic consent and collection of phenotypic data and mapping this with genomics data to navigate them in terms of, it's age of screening, we navigate you to the healthcare organization where there is a professional to talk with you. If you're before that and you have a family history, we collect genomic data and put these bits together as we're talking, bits and pieces into the whole story, where you have a consultation of oncologists or geneticists talking with you about prevention before the age of screening. And digital works there very well, because we can not only stratify, but personalize the story and differentiate the story. And it can be easily extrapolated from the Nordics throughout, the 7-hour flight towards the Gulf region and the UAE. So we so-called erasing these geographical borders in terms of, digitizing these processes, where we can easily put these bits and pieces in terms of personalization of pathway, which is very, very important.
You make such an astute point about personalizing the story, and we appreciate you sharing your own personal story of your mother, and we wish her all the best. And that's relatable, hearing news, but wanting to actually speak to someone rather than an AI app. And you're right to bring that back. And often we have these types of platforms where we might celebrate or illuminate technological and AI advancements and forget that human touch. So to hear you all say it is that much more powerful. We've only got a minute or so on the clock. I'm going to give you all a chance to give us one call to action. There's so much more we could have addressed, so allow me to say please return to the Global Health Forum and update us next year. But please, on this call to action, what might be a really big call to action that you'd like our esteemed audience to take away with them when we talk about scaling innovation, where technology can play a role? It's a big question, but Dr. Sangeeta, I know you can take it.
So I think the big one for me is really to find disease early. Accelerate cure, of course, but find the disease early. So everything we can do towards population stratification, screening using every tool and technology, encouraging through financial and communication models the culture of preventive health checks, and then helping keep people healthy so that we keep them healthy, find disease early, and reduce the burden of disease across the globe.
Fantastic. Find disease early. Luba?
Yeah, so it's an actual call to action. I don't mean
No.
call to action, do this now kind of thing, which is, you know, over the last 10 years, we've all been on panels and talked about digitization and personalization, and we speak in, it's very general. We don't usually have a lot of time to get, I love that this panel, we went into a lot of details, but this is a true call to action that we have to catch up to technology, that the technology cannot wait for us anymore. It's true, before LLMs, we could have sat around and 2-3 years thought about these grand big ideas, but today, technology is there, and in a year, what I'm worried about is in a year, we will actually have agents that will be doing things in the wrong way. And so if we're not ahead of it, if we're not there actually training, if we're not being proactive, then we will be behind technology, which is a bit scary. So my call to action would be, you know, let's start implementing, let's actually be ahead of it. And just throwing out another very quick anecdote, I know we're running out of time, but we were just training a system, an agent, and it took about, just so you know, 3 months for the agent to just learn simple biology, simple terminology, just because there aren't enough textbooks and that kind of data. But then it took about just a day to go from that level of being an 8th grade biology student to have an MD, PhD, and a 30-year experience as an oncologist for that machine. And it was much more accurate than that 30-year, that the person with the 30-year experience. So it's scary, and we just want to make sure that we bring our insights, our data, our values, our unbiased opinion into the process before we get behind.
So catch up with technology, don't be behind technology.
Exactly.
Or I think it's AI is now, not the future.
Yes.
I think you're right. But Dr. Sangeeta, we can't possibly, as women, overpower ML on the panel. Let's give the gentleman a chance to speak. Your call to action.
I'm very amazed about it, and continue listening to you for hours. But, you know, just 2 call to actions. Institutional-wise or local-wise, there is a conservatism in the healthcare industry, which is in place for sure, and it's there because we are in need, you know, to understand and validate. So let's open the doors and sit down all together and have this dialogue. Do not forget about engaging patients throughout the whole process of designing solutions. Global-wise, it's not about one country being a warrior there. Even if there is most digitized and advanced countries, we should collaborate. COVID showed us that, you know, at no time. So we should have a transparent view how to take the best from the UAE, as an example, Gulf countries, or Europe, US, and collaborate there and extrapolate these solutions in multiple geographies for sure.
And I think certainly you mentioned multiple geographies. It's really wonderful to have the world represented here with us, to hear about your multiple examples. And of course, we would love to have more time with you. But on this note, I'm going to say thank you to all my panelists, Dr. Sangeeta, Luba, Emil. Thank you for sharing your wisdom and your insights and your time with us today. And to my esteemed audience for your time. We're going to go straight into the next session. But first of all, please give my speakers a big round of applause.